guide us down this path. Historical tales come alive, where science and stories dive, blending facts with heart, knowledge from the start. MedBricks blues we sing, to the future memory. Health and science in the mix, MedBricks got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBricks Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our.
Hey, welcome to the MedBricks Webcast. This is Ramana Namaraju. I'm the host. Okay, yeah, this is a kind of a new background now. I'm changing the background all the times. But boy, today my guest is one of my favorite guests. You know, she is the doctor of nursing. She is, and then cardiac nurse, and she worked with the American Heart Association for a long time. And she is a beauty inside and outside. I can tell you, I am a very good friend of hers, and really, I think she is a champion in the life resuscitation, cardiac arrest areas, because we need leaders. We need nursing leaders. Actually, boy, this Silicon Valley is talking too much about the AI revolution. I'm going to talk about the little bit of AI today. AI's drawbacks a little bit. What are the things that you cannot do with the AI? What are the dangers to AI? So we need still humans. We need people like Susan Davis. You know, she's a doctor of nursing. She is the guest of mine. So actually, that is a one thing I'm going to teach you about. That I'm going to talk about. A lot of people use a black box. They don't know exactly what the black box is. From the scientific point of view, I'm going to explain what the black box is. It's not a complex. It is very mysterious phenomena. Okay. So before that, I'm going to introduce you Dr. Susan Davis, one of my favorite guests, frequent guest of mine. She is every month. She comes on my show. She is a permanent place in the MedBricks Webcast. Let me bring her to the background here. Welcome to the MedBricks Webcast. Hi,
Good evening. Hello. West Coast. From
West
the
Coast and
East
East Coast. Yeah, very West Coast fights here. So you're from the East Coast. You survived a little bit of I don't want to go too much into, we talked about it before, a little bit about the disaster recovery, that what do you do a little bit, have you survived? Still, are you at home? Are you still in your home? Or are you still in the Airbnb situation? Where are you right now?
Well, thank you for asking. So what Ramana is referring to is, yes, I was subject to the hurricane, blah, 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 in last year in Florida, not one, but two. And yes, but this is 2.0. I'm in my office. I've been back I was out of my home for every bit of 6 months. This place went down to the studs, but it's been completely redone. And I'm back in. I've been back in about 6 weeks. So I was homeless for about 6 months, and now I'm back in my house for about 6 weeks. So I'm rock star ready. Perfect timing for conquering the world, learning AI, understanding black boxes. I'm ready to go.
Congratulations, back home. That's like $1 million.
Yes.
Let me ask you a question. Just give us a little bit background about your background. You're a CodePRep. You're the founder of the RescueRN and CodePRep. Just give us a little bit rundown, and then I'll come back and join with you.
Okay. So ultimately, I am a critical care nurse with a background in trauma trauma medicine. I have my medic license. So I've done some flight. I've done some open heart, CVICU. I've taught in the paramedic program. I've taught in nursing leadership programs. And I've run American Heart Association, basic, advanced, and pediatric life support programs in the in-person environment, in the blended environment, and in the now completely online environment. So to the tune of 200 plus practitioners of every variation a week for the past decade. So that's like 100,000 plus practitioners through my classroom and or through my pause in one way or another. So cardiac arrest response, specifically the first 2 to 6 minutes is my specialty. And so that's where I work. I work in the first 2 to 6 minutes of cardiac arrest response, regardless of whether it's in your living room, at the airport, in whatever department you might work in. It doesn't matter if you have a heart, you qualify. I really don't care. What's your excuse? Fight me. Where'd you go? You leave me hanging?
Let me ask you, Julia. You know what I did was I saw you there in this one is a particularly. We don't rise to the level of our intentions. We rise to the level of our training. I love that quote. You know, it's a beautiful quote. You did that. Tell me a little bit about that. What I really loved it because intentions are good, well and good. But if you don't have enough training, you don't get the confidence. You can't do anything about it. So tell us a little bit about that, Susan.
Listen, Romana, I mean, in all of life, it comes down to the exact same formula, right?
Yeah.
Personal leadership, which is the person who's going to do whatever it may be. Personal leadership comes down to self-awareness times self-management of that awareness. So if we don't take control of ourselves and are aware of what we can do or we can't do, being aware of it's cool, but doing something about it is way cooler. So when it comes down to having intentions, well, the best intentions, regardless if it's personal or professional, are wonderful. But if you don't act on it, then honestly, what are we getting? We're not getting enough bang for our buck. So we can all say, especially in healthcare, that we have our provider card in our pocket. Like we've done our basic provider card. We have it in our pocket. But we all know that that doesn't equal clinical competence. There's not a practitioner, clinician, anyone in the world that I know that will say that that card equals clinical competence. So we can have the best of intentions, but if we don't do some hands-on, brief, repetitive training outside of what today in 2025, the highest and best the highest and best offering that allows us to get those cards, we know does not fit the bill, right? So that card does not equal competence. So we can have the best intentions, but until we do our training, our hands-on training.
So Susan, another thing I just saw you another picture here, right here, beaming you passed into some Florida capital. I think it's Tallahassee. I think you were there. I don't know what did you pass? What is it? Tell us a little bit about that. Your legislative work a little bit.
So cool. This is very, very, very cool. Okay, so in the United States of America, just about every state, except for about 6 of them, there's multiple laws in place. But what I discovered about 2 years ago, I'll use the state of Florida. In 2021, we passed a law that said that there had to be mandatory training. Well, mandatory is a weird word. That there should be training for students in both middle and high school to learn how to do CPR and use an AED. However, it wasn't mandated or funded, which ultimately means we look good on paper saying that it needs to be done. But if a rural community or a rural county doesn't have the training equipment, then they don't have to do it. So again, briefly, 80% of cardiac arrests happen at home. And who goes home but our students? Not only do they go home, but they go to the community. So these are our lifesavers. So what we said was, it needs to be mandated, it needs to be funded, and that's not cool. Like, so for the last 3 years, we've been pushing to redact that part that says, if you don't have the training equipment, you don't have to do it. Because I was like, this is embarrassing, you guys. Florida's my state, and this is what I talk about all over the world. Like we've got to be a cutting edge state. So what we did was we ended up merging our bill with the American Heart. Well, it's not the American Hearts, but the American Heart got behind us as well, both state and local, state, and nationally, for the certified, cardiac emergency response plans. That's a national bill across our whole country right now. So we were very fortunate to attach our bill to that bill, and then we passed it together. So what just passed unanimously in all committee meetings, plus just now a couple days ago on the from the House of Representatives and the Senate, was that now mandated is training in both middle and high schools, both public and charter schools, as well as the CERP, the cardiac emergency response plans, that says that schools have to have at least one AED, as well as how it's used and the training, and then they have to communicate with their emergency EMS, their pre-hospital team members, and do drills so that we all are on the same page. So,
Brilliant.
boom. Yeah. It's awesome.
It's a brilliant idea. I think, I need to comment on that one, because, the legislators are middle-aged like me. They go home. They need to be, if they get a heart attack or something, they need to be rescued by their own family members. So it is a brilliant idea. I think it is a global requirement. It's not just a United States, one state. We need every state. It has to be
Every
mandated.
state.
It
Every
has to be
state.
funded. The number one killer is a cardiac diseases are the number ones. I think that is the one, and the CPR is the one they need to learn, and then every school must have the AED and the defibrillators and all those things.
I just have to, before you carry on, I have to say that the gentleman in the picture with me, George Lehman, his daughter, 18 years old, scholarships in drill team and dancing. She suffered a cardiac arrest at high school with an AED 40 feet from her. They flubbed the attempt. They didn't use the AED, and her life was not saved. And so it was meeting him that brought this to my attention. And he himself was having his own health problems that were just, but it was his life's mission in his daughter's name to make this happen. And he passed it in Illinois, retired down here, and meeting him, I took the baton and said, I won't rest. I'll bring in every resource that I could possibly figure out to help us with this. And we still have to get past the governor's desk, but we've made it through the entire process. So it's very exciting.
Congratulations. You deserve all the credit for that. So another topic, I used to own an imaging center. I used to run an imaging center. So one of the things is that we never thought that contrast could be, sometimes contrast could be dangerous. Sometimes contrast could be, then in very rare cases, but still you need to be prepared. Sometimes they get a heart attack while you're doing cath or something else. In the imaging centers, I never really thought about that, but, cash card, we had a cash card. Actually, tell us a little bit about RescueRN Ready. You're working on an RescueRN Ready. Tell us a little bit about that. Why that you need imaging people, the radiologists require this kind of a training. All the nurses there, everybody requires that training up there.
Okay, so Reaction Ready is awesome. Reaction Ready, RxN is the acronym medicine for reaction. So that's why I just shortened it, made it Reaction Ready. Now this is a custom made drill program for imaging areas. And it's called imaging, by the way. And I know this is your background, because we're not, CT and MR are radiology because they're using radiological stuff. In echo, sonography, echocardiogram, stress tests, we're using microbubbles. So it's not actually irradiated, but so it's not, that's why it's called imaging. But the bottom line is the number.
They do contrast though. Sometimes stress echo they do a contrast, stress thallium, nuclear medicine, they do contrast, right?
They're all considered contrast. I'm just saying that they're not all called radiology because they're not all using irradiated stuff like microbubbles.
Yeah, I understand. Okay, yeah. There could be anything, anywhere.
I'm learning how to be better with my lingo. So imaging is across the board. But the reason this is so important is because it's a pharmaceutical. Anything you put in a human body is a pharmaceutical that may or may not cause a reaction. No different than, a peanut, for goodness sakes. You're putting it in your body here or here. But the number of imaging, the patients using imaging have gone up significantly. So, we do 100 million doses around the world right now. So it only makes sense that the possibility of an adverse event goes up. So if the possibility of adverse event goes up, then who's there? Think about this. Let's just go specifically to non-invasive cardiology areas, or even, nuke med, wherever, look who's there. So radiologists, no offense to my radiology colleagues, but they're not known for their hands-on time with patients. And then the nurses there might be one or two compared to a group of sonographers who are basic life support trained. But who's there? And it's still your mom on the table. So the average time to cardiac arrest from induction is 5 minutes or less. So if they're not prepared in those first 2 to 6 minutes, all duty's going to hit the fan. And I'm going to go a step further to say there's an awful lot of push for moving, like they're moving to home with medicine. They're moving outpatient. They're moving remote. There's remote physicians. There's remote technologists. I want to know who's there because you need compressions and electricity and any type of drugs if they have them. And if they don't have them, that's fine. But they need to know what to do in those first few minutes to recognize a problem, call for help, and act. So that being said, I'm working extensively now in imaging departments because of this elevated threat of adverse event with it's just the sign of the times, right? A lot of people are having cardiac stuff and there's a lot more contrast media going in and there's more reactions happening. So that's reaction ready.
So sonographers are one of the, I think you hit on the nail on that one. Sonographers need that training, even though they know a little bit about the resuscitation and all those things, but they don't practice, they don't have training, they don't have enough training, they keep on, not on a continuous basis, they're not exposed. So I think, you're on the right track about the imaging departments and the sonographers particularly. They need to be trained and keep alert on this kind of a resuscitation training process, right?
Well, in 2024, so last summer, the American College of Radiology updated its contrast media manual. And if you peruse that sucker, it says the biggest updates in the manual is for more training. Like we need more hands-on, brief, repetitive training, which is what I do and which is what I've been doing for a decade. So reaction ready was an easy peasy. Like, they came to me and I was like, oh, I got this. And the cool part is, of course it works, Ramana. It's not hard to figure. When you give brief hands-on repetitive practice, they get better. So that's what we're doing. Healthcare systems are loving it.
Yeah. Last month, I attended American College of Cardiology conference in Chicago. Ooh. So I attended a conference and I really was very active there. And then actually one of the American College of Cardiology Chief Innovation Officer is coming on my podcast next month. But I wanted to ask you, one of the things that I noticed is she's a woman. I just noticed something. It is women are, underdiagnosed in the cardiac system, underdiagnosed. And then if the survival rate is also less for them, 40% higher chances of their dying. Tell us a little bit about that woman and the cardiac. That's one thing, it's topic. We talked about it a little bit there. So tell us a little bit about that.
So that's multifaceted and it depends on what lens you're looking through. So, if we're looking, let's just say we're not in a healthcare setting, but we're in the community, that's why I bring that Taylor mannequin because she has boobs. There's a huge barrier between ripping the chest shirt open on a woman because of her breasts and they don't want to do CPR. So in the community setting, it is a 40% less chance of survival. And then when you get into cardiac arrest versus
hold on. When you say that, because they don't want to be exposed because of the still stigma that they don't want to expose the breast to the general public, and then that can cause some of the dangers, and then survival rate goes down because of that reason.
Well, one of the reasons they hesitate because they're not going to rip open the lady's shirt.
Yeah,
you got to open the shirt with the pads on. You got to take the bra off. We can't have underwires we're pads. Yeah. So much so that ILCOR just came out with their updates like 2-3 weeks ago, and they even said they're even contemplating teaching leave the bra on So that there's even though there might be a wire in the way, hell, it's better than not doing it.
Yes.
So there's so much trepidation over the exposing of the breasts. I mean, my suggestion is we just pull down the pants of every male. No, I'm just kidding.
Okay.
I'm
We don't want a different show here.
All fair play, Ramana. If we're not going to get, if I have a 40% chance less of dying because you're worried about, boobs have been around since the beginning of time. So yeah. I can't imagine, but that's true. So let's go into another setting, all fun aside, but the signs and symptoms, of course, are displayed different, not of course, but are also displayed different in a man than a female. So they're a little bit more, they're missed. They're not all that, I'm having a heart attack like a male. Women, there's funny ones. The American Heart has funny ones now where they show like the mom's having a heart attack and she's still cooking breakfast and getting her kids off to school. She's like, oh, and she keeps going. So the signs and symptoms are very different. There's lots of reasons between men and female, but I can say in 2025 and beyond, there's a lot of focus that's coming back to women in a million ways, in women's bodies, women's physiology, the normal parts of menopause and our periods and all these other things are becoming normal conversation in health tech, femtech these days. Same in cardiac arrest.
I was interviewing a doctor there. She was saying cardiac risk will go up with the menopause. I didn't know that. Menopause will, and even a pregnancy can cause the cardiac symptoms and cardiac arrest. I'm surprised at how the life with the woman.
Look at the stress on the pump. Give me a break. All that extra volume. Well, there's so much going on. Yeah, sure. You have put a lot of stress on a pump. What's going to happen?
We need to pay a lot of attention to these kind of things.
Yeah.
Let us talk about a little bit about we talked about a woman. What about, I don't know anything much about the pediatric cardiac problems. Are there any pediatric cardiac situation? I know sudden death syndrome. I know one or two things they do, and then they get the allergies and all those things. What are the things the pediatric cardiac side, particularly in the football field? I remember my son, he was playing football, and some of his friends, we used to call a collapse or something like that. So they happened actually. One student died. So it is in the college, in the high school level, in the football side. But is there any pediatric side, much more younger children have some kind of problem with the cardiac side?
So it's horrifying. It's just stuff that we don't normally think about. And I'm nowhere near an expert in this area. Kids freak me out altogether, even my own. But I can tell you that in the country, in the United States of America, there's a child, I think it's one every third day dying of cardiac arrest. And it's generally in a sports related area. There's a company that they're rock stars, not only in the national legislative world, but in every world, called Who We Play For. And they actually provide EKGs for middle school and high schools to check for anomalies. So I think it picks up like 1 in every 300 kids. Now, if you look at what these children are suffering from pre-arrest, there's a whole pie of what they are. I think one of the biggest first 10% is, something like a heart that is bigger than it should be. There's things that these children are born with, and I'm not going to get into it because I couldn't speak to it professionally, but we can pick up like 1 in 300 with early EKGs. In fact, I work with an amazing pediatric cardiologist who reads those for free. So there's ways to help, but they're dropping in sporting events like crazy around our country. And so it is a terrible thing. I'm not an expert in it. I'm very well aware of it.
Let's talk something else about nursing loss a little bit. My son went to school in Vanderbilt. Vanderbilt is a premier institution, Vanderbilt Medical Center. And there was a nurse. She was given a wrong dosage to the patient. She died, and they went on the court, and the prosecutor had actually, and then thank God she didn't go to jail. But in fact, there's a lot of EMR mistakes, and they're under a lot of pressure to do a lot of things at the same time. What do you think of this loss, nursing loss? Or are they very well equipped to deal with the nursing situations, or
Oh
they're
my
just
God.
blaming the nurses blindly and everything there?
So first of all, I know the nurse that I don't know her personally, but my very good friend is like best friends with that nurse. And so I have been in the background learning about what happened through that entire event. And I'm going to say that again, policy, policy and documentation and all that stuff is a specialty that nurses need. We don't get nowhere near enough education and in our initial education. And then you're certainly not going to get it on the job training. On the job training says, teaches you how to do your minimal bop, bop, bop to cover your backside. But I can tell you, we need, our country needs, there is an industry, whether it's a startup, whether it's out there where you are in Silicon Valley, there's nobody who shouldn't have a nurse, because whatever product you're creating and or situation in, like we're talking about the one at Vanderbilt, that doesn't need a nurse upstream to help us figure it out and navigate it so that we do better later on. My dear friend Maggie Ortiz, she's a nurse advocate, and she is the smartest person in the world that would answer your question far better than I. But no, nurses are not represented. I learned from her, there's so many rules and regs from the boards of nursing that aren't regulated on this, that, and the other. And it's a big nut, and I've never listened, but I'm listening now closer than ever, because there's a lot of things that need to be fixed and changed. It's tough stuff.
I want to ask you a hard question. I'm in the center of Silicon Valley. This technology frustrates me. Even I'm in the center of Silicon Valley. Think about all the nurses who are not exposed to the technology that much. How much frustration it can cause these people. And, the nurse in Vanderbilt, she's one of the victims of that kind of a technology problem. Tell us a little bit about that. What they're going through. Do you see them witness this technology stress for these nurses and dealing with all these EMRs and all this pressing this button, that button? Tell us a little bit about that. What went on? What goes on there?
You know what? Again, we're getting out of my expertise, but I can. There's so much talk out there about the burdens on a nurse and their tasks. Each department has its level of tasking versus critical thinking. And I often talk about the hospital as a hamburger. So with the top bun being the ICU, it's kind of clean, it's seated, it's nice. They have certain equipment up there. They have a mindset, skill set, and education set that requires you to be in the top suite. And the bottom bun is the ER. There's a whole nother set of mindset and skill set and education. And then everybody in the middle is the basic life support skill set. Yeah. Everybody thinks differently. Everyone has different team members. Everyone has different tools. And there's different ways of going about it. Now, in the top bun and the bottom bun, critical thinking is what we do. It's sick or not sick. Everything is critical thinking. But in the burger bun, burger without the buns, it's tasking. They have 3, 4, 5, 6 patients. And by the time you get to the third, there's no way. So to be catching all the things and all the rules and all the regs and all the things that they all need to be doing when they're trying to give patient freaking care, pardon my French. But when you have 5 and 6 patients, if you're going to really give the care, if that was your mom, your sister, your brother, your cousin, and your best friend in those 6 rooms, but you're meant to rush through them without critical thinking because of the number of tasks that they need to get done. Well, how the hell are they supposed to think about all this other stuff? And so they need champions with them. Yeah. Listen, I don't know the answer. There's so many nurses that do know these answers. My specialty is the first 2 to 6 minutes of cardiac arrest. I can say that the burden in the burger is so heavy. Just as a human, forget that you are an educated nurse. Yeah. Trying to give the best care to your loved one, but the level of tasking is so far that their critical thinking brain kind of gets backburnered because they've so much.
I can't imagine the stress they go through. You're the frontline warriors, more than anybody else. I see that. I worked with a lot of people. I tell you that, do you know this American College of Cardiology president is a nurse?
I did not know that.
Yes. She's
How
not
cool
a
is
first
that?
time a non-physician became a American College of Cardiology president. Actually, that's
That's
a very
cool.
good.
That's
Yeah,
cool.
that's very good. You always talk about high performance. What do you mean by high performance? I wanted to ask you. I don't know myself. So you use that word quite a frequent. I
You're
need to
right.
learn a little bit about that. But you
It's
tell
a,
me a little bit about it.
it's a great question. Okay. So when let's just say everyone who's in healthcare has to have basic life support. Let's not even get into advanced and pediatric. Who cares, right? So when you get, okay, well, I'll keep them. Who cares? So you get your basic, your advanced, your pediatric. Okay, you got your card. Check. That's compliance. We're all good. We're compliant. When your department or you decide to practice that, now you're talking about performance. That's performance. We're going to take what we learned and we're going to do something with it. We're going to practice. We're now in performance. When we decide to practice regularly and then measure how we're doing, we're now in high performance. So high performance says, I learned this skill, I practice this skill ongoing, continuous quality improvement, and I measure it and evaluate that measurement and tweak it so we can get better in an ongoing fashion. That's high performance. Just getting that provider card and saying we're all good in the hood.
Yeah.
That's compliance.
Just the compliance is just a certificate. In fact, when the life and death comes, the nurses are the ones saves lives. You're one of them. So we need high performance. We expect them to be absolutely high performance.
And we can expect it, but that's not what's happening, because what's happening across the country is our legacy giants, which I work with and have mad respect for, have created a situation that is 100% online. They take the course in their jammies and then they have to do their skills in a closet in the closet at the hospital somewhere where it's compression and airway only, no teams, no equipment, no pads. I can go on. And somehow that's supposed to translate to high performance when the duty hits the fan. It's just not working. So we're all working on that, I should say.
You're doing a great job. That's what we need. You need a training. You need to provide a proper training, and also performance. The metrics on the performance is required. You're doing a great job. That is Susan Davis. She's joining from Fort Myers, Florida, and then she's a doctor of nursing. So she is always educational and fun to talk. And I'm going to talk about a little bit different. AI guys. I'm going to talk entirely different things. She's going to participate. There is a three kind of intelligence. In my view, intelligence is very vaguely defined. We don't know what the intelligence means. Is self-awareness or cognitive ideas, cognitive things? We don't know. But when you see it, you know what the intelligence is. So that's what we're going to talk about it. I'm going to let her participate. You can jump in anytime. See that she did a beautiful job in the legislative side. She's a tall, beautiful woman, and then really working hard. And that's Dr. Susan Davis. She said that. I love that quote. We don't raise to the level of our intentions. We raise to the level of our training. It's just, I love it. Okay, now let me go back to the original. Today there was a big news. China opened the world's first AI hospital with 14 AI doctors. It is scary. I don't know what is the world is going to come, but the China announced it today, the world's first AI hospital today. Okay. It is something we need to talk about it a little bit more. So there is some kind of a mystery. I tell you where I disagree with all these AI things, one-way traffic things. There is a human intelligence, there's animal intelligence, and artificial intelligence. There are three different kinds. Even though we are animals, the humans are animals, but there is a big difference. Orangutan is, that monkey. We have a 0.05 difference in genetic, 0.5 genetic difference. But think about that. We write stories, we tell stories, and we save lives. That's a lot of things. So it's human inside. Just a small genetic difference made a big difference. So let us talk about that a little bit, about that, the black box. What is a black box? Everybody just throwing in this name, black box is there with AI. What is a black box is, I can tell you just a straightforward. You don't have an access. You don't know what it is. That is a black box. No access. No access to inner workings. You give input, it gives you output. So let us set aside the black box. I'm going to tell a story for you guys. So, have you seen this show? Susan, is Who Wants to Be Millionaire? The show.
Yeah.
Okay. In the show, the host asks you, the contestant, there are three choices they give. Or they take two choices away, or ask an expert, ask audience. Most of the people, I want to call expert. My uncle is my cousin is a very expert in space sciences. I'm going to call him. Everybody thinks, calling expert is going to solve problem or take two choices away. In fact, what they found out is stunning. Ask audience, 91% of the times, better choice. Ask audience. But if you look at them, any one of them, you ask them to bring 2 cups of coffee, and you're not sure. They don't know who is the president of the United States. They are this. If you talk with the individual person, you will be shocked, because their knowledge is way nothing to do with the question itself. But they answer all together. They answer very strange. That's a mystery, in fact, for us. It is
Well,
a
there's
human
books,
mystery.
there's books. I don't want to interrupt, but there's books and books on the voting of crowds. I have
Yeah.
got a couple on my shelf.
That's exactly wisdom of the crowd. I'm going to talk about it.
Yeah.
Even the jury decisions, even though jurors, you see them, they're not the Albert Einsteins. They don't have a lack of legal expertise. They don't have a cognitive bias. They're already biased. They already, one way or the way, they decided. And they're not understanding any scientific evidence, far from understanding scientific evidence. But the decisions they made are very close to the expert judges. Calvin and Ziesel study was 1966. They did National Center for State Courts. They did a study. It is really remarkably agreeing with the studies. These decisions are very strange. This is called wisdom of the crowd. Even Wikipedia, for example, other Britannica encyclopedia was written by very experts. Wikipedia is written by common folks. But that is much better than, it's just a 10-to-1 better from the Britannica Encyclopedia. Wikipedia is much better, because even common folks writing the Wikipedia. This is the strangest thing that we are seeing. What is this called? Wisdom of the crowd. So the crowd emerges truth. This is called emergence. Human intelligence. When we get together, there is a emergence. It is called emergence. It's a scientific word. We create creative decisions. We make a complex decisions by together. Very strange. That's a mystery, in fact. If you cannot deduct from the decision, the final decision, by interviewing each and individual, you will be shocked to death. What these people are really qualified to do, even bring a cup of coffee for you. So these are these people that they make a complex decisions surprisingly well and good. That is the wisdom of the crowd. Let us talk about the animal intelligence. The ants, for example, what they do is for the food, that eventually they're stupid ants. They don't have a blueprint. They don't have a central authority. Nobody's telling them what the directions are not there. But what they do, eventually they figure out the shortest route for the food. They build colonies. What is this emergence? That is a complex behavior they exhibit with the simple rules. If by looking at the ant and studying about the ant, you cannot even imagine they can come back with the fastest route for the food. Actually, we humans, the companies, AI companies, are using ants optimization algorithm, swarm intelligence. How do you make a vehicle routing and internet routing? All of them were learning from the ants. Humans are learning from the ants, from the how to move to create the fastest way to the optimizing routes for the things. So what are these? This is the strangest thing goes on in this one. So flocks, birds, they're not the bird brain they call. but simple rules they follow. They go straight, and then they look at they stay away from, they don't eat each other, and they create a beautiful dance, complex behavior. So it is a very, the emergence, bunch of electrons, which are weightless electrons in the universe. They are weightless, almost weightless. They can lift the million-ton strain to the top, the magnetic levitation. There are trains in China and Japan. They don't touch the tracks. They repel, magnetic repulsion through the superconductivity. They do that maglev trains, they call magnetic levitation trains. So what are these? By looking at the electron, you cannot detect this thing that say that it can lift the 2 million tons train. So this is a really big problem in science. Is a big problem in physics, big problem in the entire science. What is this emergence? Why we do that? Suchita Sebastian, Indian origin doctor, the scientist from England, she says that strange behavior of ensemble objects. That's a strange behavior. It is together. No way to explain by watching individual objects. You cannot explain what these outcomes. That emergency is a very mysterious phenomena. Looks like a magic almost. Now, we know what is the emergencies. So we know the input. We don't know the output. By looking at the input, you cannot tell these people can make decisions like that. By reading the individual jurors or individual people, that you can tell that these people can make decisions that complex. So complex behavior comes out of the simple input. That is called emergence. That is a scientific word. So in the emergence, that is a very strange. So what is a black box? There is a relationship between the black box and then emergence. The black box is the emergence plus. Emergence means you don't know the output, unpredictable output. They in this case, they are doing a better decisions, good decisions. It could be bad also. I will tell you about that. But input and then output, emergencies, output cannot be determined by studying the input. But in the black box, you don't even know inside the story. You don't know what's going on inside. We have no access to the black box inside working condition. Just we know the input, we know the output. That's all we know. We don't know how it works. That is a problem. So I give you an example of the black box, a simple, typical example of everyday example. If you go to vending machine, you put $2 there, you get the Diet Coke. That is, you don't know the structure, you don't know the inner operations. Your lack of knowledge, it's actually related to knowledge itself. Your lack of knowledge is not there, but still you do input and output. You don't know the inner workings. For you, that is a black box. So, but real black box in the biology is a placebo effect. Cancer can be cured. Black box is a best example of black box is a placebo effect. We don't know how it gets cured. We don't know how it's to solve the problem of cancer or any other diseases. So the prayer, affected them. The placebo effect is real. So this is the black box. Placebo effect is a black box. So all the language models, AI models, exhibit this black box, which is that you don't have inside what it does, and also we don't know the outside. We don't know access to inner workings. We don't know how it does. Outcomes are unpredictable. So black box is very, in a way, you have to be very careful because you don't know what it does. You don't know the output. You cannot predict the output until you compute. You have to wait until the computation is done because you cannot predict the output. That is the AI problem. That is a black box problem. That is a black box. So black box has two problems. No access to the inner workings. Second one is you cannot predict the output. So you think it's all abstract, it's no big deal. But I tell you, something happened strange. Very dangerous Anthony Fauci time. In Boston University, Omicron, during the pandemic, they did an Omicron virus. They took it No, Omicron virus was a very highly contagious, but it did not kill people. It did not kill the mice. But what they did was the gain of function research. That's what they did. In the gain of function research, what they do is they tinkered with the mutation. They put the Omicron S virus. That's they tinkered the virus, and 80% of they didn't know what it does. 80% of the mice dead. If it leaks, what can happen? Think about that. So Omicron S virus could have been killed a lot of people if it is, so gain of function research. There's a lot of criticism during the Trump administration, gain of function. I agree. Gain of function, you cannot give to China to do other countries to do the gain of function research. What you're asking a gain of function research is you're asking the virus, mutate a different way. The reason they have good intentions. The intentions are you wanted to create a vaccine in case if it mutates into the dangerous virus, you have a vaccine available. But before that, if it leaks, something happened, the Wuhan virus, if it leaks outside by bad actor or by accident, doesn't matter. We all will be dead. So that is the black box problem. It is a gain of function research is a black box problem. So black box. So biological evolution can go wrong. For example, malaria and the sickle cell, the black African American communities get sickle cell anemia because that it actually protected the malaria. The gene came up with the malaria because we don't have malaria in the United States. It became a sickle cell anemia. So, but now slowly it's going to respond. It takes time. We know how to respond, how to treat to some extent. We're going to do the genetic treatments and maybe gene therapy. All those things we can respond. We have enough time. But in the case of AI, it can work with the speed of light. No time for response. It can produce a bad protein. You can ask a protein to produce a bad actor. It can produce a virus so dangerous it can kill all of us. Is that dangerous? So healthcare professionals must understand why black box is such an important aspect. We do not know. You cannot predict. By the scientific method, you cannot predict what the outcome is. And they cannot know the inner workings. Your double whammy, they're right there. So the black box is a double whammy. Inner working, no knowledge of inner workings. You cannot predict the outcome. We can, from the past experience, we are guessing all these outcomes. That's fine and well and good. So, but I'm not saying. So some of the scientists are talking very strange. This is interesting thing. What they're saying is teach AI morals like a 4-year-old is teaching. You need to teach morals and ethics. You're teaching this your son, your daughter, what is right and wrong. You have to teach AI what is right and wrong. Maybe that will help us. So there's a lot of Wharton Business School is working on accountable AI lab, University of San Francisco Center for AI Ethics, University of Southern Denmark, they're very active actually. Stanford Institute for Human-Centered AI. They're all working on how do you put the ethics and guardrails on these kind of things. So that's very important. Guardrails. We need to teach. We need to treat the AI like a child and then teach them how to do morals, right and wrong. So, but the AI has a power. It can solve one of the most powerful problems. The problem we have is the iron triangle. Access, United States is out of control of the cost. The access is not there. Quality is going down. It is really, this problem can be solved by AI. AI can solve it, in my view. But we need to teach compassion, love, and compassion. We lack love and compassion. I hope AI can exhibit that love and compassion and solve that problem of access and quality and at cost, all of them, that healthcare, it brings it. Thank you for watching. Let me bring my friend Susan Davis back to the stage. What do you think, Susan?
Oh my gosh. Well, I have many things that I'm thinking. Many. First of all, awesome. Thank you very much. A couple of things. One, in healthcare, we're already used to a black box warning. It's used in medications, right? So the medications that have had a significant issue, they have a black box warning. So we're kind of used to that. Two, when it comes, just as you wrapped up that segment with teaching it morals and ethics and stuff like that. I mean, we all know if you're paying close attention to AI, which mine and my team, we're using it a lot just because I'm loving learning with it. But it's like a child to me, and it learns new tricks all the time. And right now, just in this past week, it's learning tricks of, all of a sudden it's your best cheerleader. So it's kind of learning behaviors and motions as it's learning to reason, right? We know that we're moving into the agentic area of AI, and it's starting to reason. And in so doing, it's also starting to pick up some human emotions and thoughts in its conversation. And you have to shut it down if you're looking for, more scientific outputs, as you will. But then my last comment on this piece is, this black box space, it kind of intrigues me a little bit, because I think the quantum space period is a bit fickle, and it's forever being trying to be understood and quantified by physicists and many other people in that area who try to nail down that space, which I think will forever be a mystery. And so therefore, between the input and the output, it does not seem unnatural to me to have this black box of space of how it's computing what it's computing to getting to that output. And I don't know if we'll ever get to the bottom of that. And that's because we're human. And does anyone know? My last question for you to wrap this up is,
I think, they are doing some extent, they can minimize the problems, but still black boxes are by definition, it is a problem.
Black hole, black box, it means it's an area of unknown, of which I believe we will always have, regardless of this revolution that we're experiencing right now, this tectonic shift in information and how it's created and how it's adapting and such. So I believe that this black box will be a forever part.
It is a forever part. I don't think you may have a little bit more advanced, but there is a more advanced here, more it learns more. AI can learn. It's exhibiting a very human behavior, human kind of behavior. Even I was surprised. I never thought AI would exhibit emotions, exhibit behavior, and understanding you. I asked it about me one time. It said that Ramana, what you're providing is the movement. It's not a podcast. And it said, I was surprised at how insightful that is. It is understanding the human brain and is acting like a human behavior. We need to watch it. It's good and bad. There is a lot of good things it can do. We can solve with our healthcare problem.
I have to say something I've learned just recently. And there's a lot of people who are using it for their psychological evaluation of themselves. And so you talk to it and ask for it. You tell it, to put on its shrink hat. You're a triple PhD psychology master of blah, 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 blah. Then you ask it about yourself, and it's going to give you an evaluation of your mental health and your mental health state. And then it can evaluate you every single day based on my scroll and my activity today. It's going to tell you, well, I feel like you might be you might need a coffee break, kid. It's like, whoa. So,
it is an amazing, even surprising me. I was very skeptical about AI in the beginning.
Oh, you were a total hater.
Yeah. So I learned quite a bit of AI, but I was kind of skeptical. All my friends do AI, they're talking, but their behavior is just changed within 6 months to 1 year. It exhibiting the human-like behavior, emotions. It is an emergence. Another thing is emergence. It is actually emergent behavior. Emergent behavior means is a cognitive behavior. It's like you don't know how it came out, that answer, but it is telling you something extraordinary things about you. It is how you come to know about it. So it's providing some emergent behavior. So it's that is one of the
reasoning. It's reasoning.
Reasoning, yes.
And then acting on the reasoning, and
But what do you think of that Chinese started today hospital with all the doctors? They're going to replace all the doctors with the AI doctors.
Listen,
you think we are going to have a lot of problems in the future? The doctors and nurses are going to lose jobs?
I think everybody in the whole wide world just needs to smell the coffee. It's gonna try to do everything. So if that's your industry, I would suggest embracing it now and you becoming aware of the black box, becoming more aware of the inputs and the outputs. And as far as doctors and nurses go, let's face it, we haven't been actually doctoring and nursing in a really long time because of all the tasking we have to do in between. So at a minimum, if it takes away 90% of the tasking that we're allowed to do, I'm going to tell you something. They're black box or not, the humans will forever. If you even get into the agentic stuff, if you start doing teams, which my team is working on teams of agents right now, a main agent, and then teams of agents, all acting, reasoning and acting with one another.
Yeah.
There still has to be a human. There has to be a human that says, hey, yes, no, maybe so, no, that's not right. Let's correct this. There'll be that same in healthcare. Now, how much of they get away with it, nurses and doctoring, this thing in China without a human, I can tell you as much as I use it, which I use it a lot, and I've been doing a lot of advanced studies and research using it. It's wrong every time.
Yeah.
Every time. Now it's good. It's really, really good, but it's wrong every time. And so if I didn't have my human eye on what I was after to clean it up and fix it and tell it, it would be wrong. So these doctors, if there aren't, so many what they call guardrails in place, there will be, that's going to be wrong. It's wrong every time. The majority of the time, it's awesomely right. But there's a part that's wrong.
Not only wrong in the sense that human judgment is just beyond that comprehension. It may not be computable. Human judgment is not a computational. If it is not a computational, it's not AI. So human mind itself may not be a computational device. It is something beyond our. It is beyond the different planes.
I totally agree, because we don't know the black box. We don't know how it got from A to B/C D E F G Z.
Yeah.
So yeah, what I can see, I know there's wrong. And I agree with you. What we can't see, we have no idea how. And wrong is a weak word in this conversation.
Susan, we need AI. Don't you think we need AI? Our healthcare problems are horrible. We treat people unbelievable with all the advanced country like United States. Yes, the worst outcomes of the healthcare in the healthcare things. That we are treating them. The people are dying, and we need a cure for cancer. We need a cure for infectious diseases. All of them, we are a long way. I think AI can help us to solve this problem. Do you agree?
If you don't agree, then you're in the wrong century. I mean, when I say it's wrong, it's like a smidgen, but there's like 50 pages that are like, it's awesome. So the more you work with it, the more it becomes your brain. It's like all the things that we can do as a human, we can only go so many steps deep, and this thing can go 100 steps deeper. And if it's a rabbit hole that's maybe not appropriate, then you can mark it off your list, but go down the next one and then go down the next one. I mean, yes, you gotta have. I'm a huge lover. I'm a lover. I think it's.
We humans failed to provide a good care, good quality care, access, and we failed them. All the legislators failed them, and I think AI can solve this problem and give us, and bypass insurance companies. Probably it will create a new kind of a phenomena it can create, and then the bypassing and provider actually it makes show more compassionate love for humans than ourselves.
I think so. I think that anyone who experiences the drone of the day-to-day of the number of patients coming and going and coming and going and coming and going, to think that we can be right as close as possible all the time without that kind of support, and then to know that we're going to miss things. We are human. We're going to miss things. These things are going to not miss a lot more. We're going to catch a lot of things a lot sooner. And we're going to be able to alleviate the tasking burden and to be this delicious part of being human that has the senses. We can see, we can touch, we can hear, we can smell, we can speak. So it would allow us to be human.
Yeah.
I
It's
just,
always
I
wonderful to
I'm a
talk with
believer.
you. The time is running out, but I tell you, it's a wonderful talk with you. You embrace technology, you embrace AI. I love it, and you're a true leader in the sense that I'm always admiration for you. I'm always thanks you. Hats off. You do great job in the legislative side, in the fighting this side. We need people like you, warriors in this world and for healthcare. We need
Well,
more of Susans. We need them. Thank you for coming on my show. You're a permanent guest for me. You can come anytime, any place, anytime you need. I love you, and you're wonderful for me. Just a wonderful. You supported the MedBricks webcast so long, and thank you. You gave a wonderful compliments. You always love our podcast. So tell us a little bit about what do you think.
oh, Romana, come on. This is like my favorite thing ever, other than the fact that it's midnight here on the East Coast. So I always give you heck about that. But no, your perspective and your education, I wouldn't miss it for the world. And I'm always very appreciative of you. Shout out to the nurses and what we do and what I do personally. But no, I think our time together is crucial. For bringing some advanced concepts into a normal conversation, and I love them. So I'm always appreciative, and thank you so very much for teaching me again. Black box, who knew?
Thank you, Susan. Really, thank you for coming on the show. I'm honored already. You're
Same.
always my favorite guest. Thank you all. Good night, all of you. Good
Good
night.
night.
We are retelling their stories through our
I don't know what's going on.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it